Okay, we're going to get started. My name is Belinda Sims, and I work at the National Institute on Drug Abuse in the Division of Epidemiology Services and Prevention Research, and I'm a program officer in the Prevention Research Branch. And it is my great pleasure to be here this afternoon to moderate this panel, what we're calling Panel 3 Intermediary Groups, Services and Programs for Two-Generation Approaches. And I want to thank Jeff Levy for giving some mention to intermediary groups in his remarks. I thought that was perfect timing. And so what we're going to do here is similar to the other panels. We're going to have some opening remarks from each of our panelists, and then we're going to have everyone address our overarching question and then a few follow-up questions before we open it up to the larger group for discussion. And so I'm just going to do a brief introduction of our panelists and then have them go in turn instead of standing here introducing one after the other. And our first panelist is Shikha Anand, who is from the National Institute for Children's Health Quality. And our next speaker after that is Parinda Khatri from Cherokee Health Systems. And Parinda will also be giving the perspective from two additional activities that she's involved in with the Collaborative Family Healthcare Association and Patient-Centered Primary Care Collaborative. So bringing in multiple perspectives. And then we're going to hear from Johnschlatt, who is from the School-Based Health Alliance, and Karen VanLandeghem, following that, from the National Academy for State Health Policy. And then our last panelist is Sara Watson, who is here representing Ready Nation. And so as each of you give your opening remarks, I think it would be helpful if you could give some information about your organization, and in particular, giving some attention to how your organization facilitates services and programs for children, as well as those that extend beyond the child to include parents or others in the child's environment. Thank you.
Great. So now we all know about my technological intelligence. It's wonderful. I never get by without revealing that. So good afternoon, everyone. So I'm Shika Anand. I'm from the National Institute for Children's Health Quality. We are a national nonprofit located in Boston, and we focus on large-scale initiatives to improve the health of children, really spanning health and healthcare. We began with a focus on improving healthcare quality, and over time have expanded into the public health as well as the community realms, with a big focus on family engagement as we do this work. I think we run about 20 different programs at any given moment in time, all of which are really related to this topic in some way, because in our mission we serve vulnerable children, and those are children that are either emotionally or socially or medically vulnerable, and clearly the behavioral health needs of those children are evident. So I'll focus, just for the sake of brevity, on 4 initiatives, and I'll be very brief about them, and then if people want to hear a little bit more, you can ask in the questions. So the first is the 100 Million Lives campaign, which is actually being run out of the Institute for Healthcare Improvement. And we're actually leading the child health efforts for that campaign. And really, it's a multi-community, whole-of-community approach to promoting health, and very broad definition of health. And within that work, we're really focusing on promoting socio-emotional development and creating access to behavioral health services and community supports, as well as to build the capacity of the healthcare system to address these issues. And this is across the lifespan and will be happening throughout the community, and we will actually be doing the child health carve-out within communities that have a broader approach. And that work is just launching, so the communities are just being selected. And then we have 3 other streams of work that essentially span the life course. The first is we do some traditional work in medical home implementation with a focus on behavioral health integration. So Greg Hagan mentioned a little bit earlier the Massachusetts CHIPRA demonstration grant. Our organization and I myself led the Learning Collaborative for a demonstration in 13 13 practices across the Commonwealth of Massachusetts. And we worked a lot on behavioral health integration within the primary care setting. So a lot of the models that have been discussed earlier today are things we worked on with a variety of practices. As Greg mentioned, these practices range from a 2-partner private practice to the faculty practice at the Children's Hospital of Boston, which I don't even know how many FTEs it is, but quite a few. So really diverse systems and really understanding the challenges around connecting with communities, around building agility into the system to promote behavioral health integration. So I think, it's important to recognize that when we talk about behavioral health integration, we're not just talking about one thing. We are talking about many, many things, and they depend on the assets of the primary care practices or the medical homes, as well as the assets of the community. The second thing I'll point to is actually that we are doing some behavioral health integration specific work with another group in Massachusetts, building on the work that we've done. And in this, we will actually be thinking about how to access psychiatry as a referral resource, telephonic consultation, et cetera. And then the next initiative I'll talk about is our infant mortality work, which is in 56 states and territories. And in this work, even though it's infant mortality, it seems like it might be less related. We're really focusing on screening for and addressing behavioral health issues and substance use in women of childbearing age as a point of prevention to infant mortality and poor outcomes in infants. And then the last piece I'll speak to is our early childhood work, where we're promoting socio-emotional development in early childhood, and we're partnering with the Einhorn Family Charitable Trust as well as potentially some other funders. And I think in this work, what we're really talking about is, again, a primary care focus, but thinking about it in a very different way. So what Neil Halfon said this morning about the pediatric office is true and necessary, right? We need primary care to be connected to all of the different agencies in the community. But we're still in this framework of looking for defects and then correcting defects. And being a practicing pediatrician, that's not actually the most rewarding part of my job. Not that work does not need to be done. We need to both think about the 4 to 6% that Neil talked about, the marginal risk, as well as the medium risk, the 30 to 40%. But in this work, we also want to focus on the good enough, as Neil put it. And we don't really believe that the good enough is good enough. So in this work, we are actually convening a group of experts to identify nurturing behaviors that can be easily identified within the context of primary care, where pediatricians can, or other providers can give positive reinforcement for what's happening in the exam room. So, very closely tied to what we're talking about today, but really taking a step back and covering a broader audience. I'll stop there for now, and I'll pass it on to the next panelist.
Well, thank you. I'm going to talk about Cherokee Health Systems, which is, job number 1 for me. I'm Chief Clinical Officer at Cherokee Health Systems, and then I'll give you a brief overview of CFHA, the Collaborative Family Healthcare Association, and the PCPCC. Fortunately, they're not incredibly different. So a lot of the, I think, overarching issues overlap. So Cherokee Health Systems is a comprehensive community healthcare organization based in East Tennessee, and we provide integrated primary care behavioral health services. So we have about 24 clinics in 14 counties in which we provide integrated primary care behavioral health. We've been doing that since 1984, integrating behavioral health in primary care. We are comprehensive community healthcare organization, which means, we see people cradle to grave. So we don't just see, children and parents, we see cousins and grandparents and great-great-grandparents. So in many of our clinics, we just see generations of families, which is a real gift and honor for us, in terms of our role in the community. For us, our patients really led the way toward integration. They showed up with our doorsteps in these rural areas where there were no services. So they kind of showed us, like, look, you have to pay attention to this and this and this. And so what we do is really bring together our behavioral health providers. We have psychologists, social workers, care coordinators, community health workers, integrated psychiatrists, we're all on the same team. And in fact, we want everything, we want to do everything we can at the point of primary care. We are also in the schools. We have some school-based health clinics, and we do telehealth into the schools. If any of you have been to East Tennessee, you know that we are, the Appalachian Mountains are beautiful, but they're also very remote. And we have some school systems and counties where there is just very little to offer in terms of care. And for someone to come down to the mountain and take time to go to the clinic is not going to work. So we have our pediatricians and pediatric nurse practitioners beaming into about 25 schools in the mountains in East Tennessee. We have clinics in migrant farms. We have a migrant farm center. We also have a clinic in the local pediatric clinic in the local health department right next to the WIC office. And we have a clinic right in the public housing project in Knoxville. We also have a homeless clinic. So we're very much about, we have a saying, Cherokee goes where the grass is browner. Wherever there's a need, we're going to go. And so our goal has been really, as we heard, to try to meet this healthcare 3.0 as much as we can, given kind of where we, given the infrastructure that we have to live in. So in terms of our pediatric care, we have psychologists involved in every well child check. So they do the anticipatory guidance. Someone had talked earlier about team-based work. They will do the screenings. They'll do the anticipatory guidance. Our goal is to address issues at a subclinical level before they turn into a diagnosis, right? So that has been a really fantastic kind of integration effort. We have developmental psychologists who are trained, particularly in the autism spectrum disorder. So when we can screen, we can and something's positive, we can do that at the point of primary care, follow up with the more intensive evaluation. And then from that spectrum in terms of wellness, we also then are trying to target high-risk populations. So we have partnerships with DCS and the foster care system to have a center of excellence to provide kind of optimal care coordination for children who are in DCS custody or at risk for DCS custody. And then we also, for example, in our prenatal clinics, we provide high-risk OB care because nobody else would to, frankly, a very, very high-risk, vulnerable population. And our goal really has been to reduce the risk of NAS, the neonatal abstinence syndrome. In Tennessee, it is horrific. And in East Tennessee in particular, it has just become a tsunami. So really, our goal has been to improve birth weight and also reduce the rates of NAS. And the only way to do that is to work with these moms who are, many of them, rejected. Either they don't get prenatal care or they've been discharged for a positive drug screen. We say, please bring them to us. Bring us, you're tired, you're hungry and poor. And we have integrated teams, so every one of those women, every single visit sees a psychologist, case manager. We help them with housing, we help them with transportation, with food, parenting. And our goal is for them to be able to take their babies home. Most of them typically would not be able to do that. And then we also then want to link them to our pediatric clinic so we can follow these kiddos given their high risk. So that's a little bit about our organization within this community health setting. The Collaborative Family Healthcare Association I got involved with because the focus of CFHA is integrated behavioral health and primary care. And the word family has been in there, and in fact, people have wanted to take it out because they've said, well, integration doesn't really involve the family, it involves the individual. And these are the folks who are like, these are the folks who focus more on chronic disease management, and we had to fight to keep it in and say, no, if we really want to change the healthcare landscape, we're going to have to focus on the family. And so CFHA really is a convening body. We have a conference every year where anyone who's interested in collaborative care can come. We have special interest groups. We really just see ourselves as a convening organization where like-minded individuals can come and share ideas and get support. And as you can imagine, CFHA is 25 years old, and it's now everyone's talking about it. Before it was just considered these very small kind of fringe people in the on one side of the room. And then the PCPCC is the patient-centered primary care collaborative. I kind of, we've all these pediatric providers. I mean, pediatric providers were doing this way before. Here, people now are talking about PCMH. My sister's a pediatrician, and she's like, pediatrics was doing this way back in the 60s, 70s before it became the hot thing to do. But with PCPCC, the focus is really trying to take what pediatrics started and enhance it to create a really strong medical neighborhood. And really the goal of PCPCC now is not to let primary care get lost in ACOs, because ACOs can be great, but they're huge entities. And so how do you kind of keep that focus on the medical neighborhood and patient-centered care at the primary care in the trenches level? So.
Good afternoon, everyone. I'm Johnschlatt. I'm the president and head cheerleader at the School-Based Health Alliance, a privilege I've had for nearly 20 years now. And I am pleased to bring the voice of school health services into the room today. By the way, I'm not the lone voice. And Shep Kellum, I thank you for your advocacy. Kelly, I don't know if Kelly's still here. I was glad to hear Kelly talk about the role of schools. Neil, of course, we are partnering with Neil in a body of work around child health transformation that I'm delighted. Their vision includes schools. Neil, of course, described it this morning as the flea on the fly of the horse's tail. School health services. So I guess that's what I'm here to represent. The flea on the fly of the horse's tail. Small but mighty, we like to say. He also talked about an audacity deficit, and so I want to start from that framework, the framework of audacity, because think of how audacious it must have been to think, what if we took healthcare out of the medical complex and moved it into the neighborhoods where kids are, specifically in the schools where they learn and grow every day? And what if we thought differently about what medicine is and brought a team of providers together, integrate the notion of primary care and public health and oral care and health education and nutrition, and brought that team together and brought that force into the school to help disadvantaged children? What if we moved upstream of disease and got to kids earlier, before disease sets in, before unhealthy behaviors set in? What if we thought about a whole child approach to care, where we're focused not just on the head or the body, but on both, but also on the day-to-day functions they need to succeed in school? And that has been mission central for school-based health centers. That's the organization that I represent. There are about 2,400 school-based health centers across the country. They represent a shared commitment between school systems and community health organizations that say, we are in it together because we're both better when we intersect on behalf of children and adolescents, particularly a group of children and adolescents who have suffered great inequities in the healthcare systems in our communities. And we've talked a great deal about that. We know where the disparities are in health outcomes among children and adolescents, and we know the inequities in our health system, and that the trickle down of healthcare policy doesn't trickle down to many of the children and adolescents in their communities, and we all know who they are. So school-based health centers were long considered a symptom of a healthcare failure, a Band-Aid, if you will, until something better comes along. But I think they are the progenitors of healthcare transformation. As Parinda had just pointed out, they understood 30 years, 40 years ago, taking medicine out of the health complex and moving it into the schools, doing integrated care. They have been doing it now for decades. One of the things that school-based health centers understand is that the greatest thing, let me rephrase that, I don't want to be considered hyperbolic. One of the greatest things that we can do to help children and adolescents enjoy a lifetime of good health is help them graduate from school. That's probably one of the single greatest things that we can do. So my members think every day when they go into the school, what am I there for to do? I am there in service to the school's mission. Yes, I'm a healthcare provider and I care about their well-being, but the school will only want me there if I can prove to them that I am attending to the children's academic success. And so we focus on how do we get them back into the classroom sooner? How do we focus on children who might be suffering from asthma? And if we can manage that care better in the school-based health centers, they're less likely to miss school. Chronic absenteeism, as Jeff pointed out, is a huge issue that has great public health consequences. And it's a role community health can partner with schools through school-based delivered care to address some of the health and behavioral health related consequences of absenteeism. So that's the primary mission of what school-based health centers do. Again, I want to say they are partnerships. They are a manifestation of community health working in and through the schools to deliver high-quality care, prevention-oriented care, and attending to academic success in the classroom for all children. We are a two-generational model in a way that you might not think about. And yes, families are certainly very present in the minds of healthcare providers in schools, because you can't provide pediatric healthcare, particularly to kids in elementary school, without communicating with mom or dad or the guardian. It gets a little harder in adolescence, I will concede, because they want to be autonomous and more independent. But certainly parents should be and are engaged in children's healthcare. Some communities have actually opened up their doors to moms and dads and siblings because they know that there's a segment of those moms and dads who have no other access in the community, particularly in communities where English is not their primary language. And they trust the school as the only societal institution in which they feel safe and coming to get any kind of service, because their children are there every day. And so for some families, going to the school to get health care is not a bad way to get care. For adolescents particularly, the school setting provides a normative experience around behavioral health that is difficult to achieve in community-based settings where there is some stigma attached to going to community mental health settings. And so when it happens in the context of school, in the context of their daily life, in the context of a setting where somebody may be getting a sports physical or an acute care checkup or an ear infection, they could also be getting checking with a counselor around a mental health visit. So it normalizes health care seeking behavior among a population that isn't quite good at getting care. But I wanted to wrap up with the two-generational idea, and is that we're thinking a lot more and pushing our field to think about the adults in the school building. That's the generation of adults that we're thinking about, because their wellness matters a great deal to students too. Because when the teachers feel stressed, the students are going to benefit from that. So having health authority in the schools and allowing them to be thinking about staff wellness and promoting a culture of health, if I may. I know Paul from RWJ is here. How do we create a culture of health in schools that starts at the leadership of the school building and trickles down through all the faculty and the staff, and most importantly, of course, to the students? And that's the power of what school-based health centers can do. I won't pretend they're all doing that. I won't pretend that they're fully realizing that opportunity, but I think they understand it, the power to be catalysts in their communities. And we as the national organization are really pushing to give them the skill sets and to change policies around which all of that can happen. And we'll say a little more about the ACA in the next round.
Good afternoon. My name is VanLandeghem, and I'm a Senior Program Director at the National Academy for State Health Policy. I want to thank the Board on Children, Youth, and Families for asking us to be part of this panel and this day, and it's been a great discussion so far, and so really appreciate being invited. For those of you who don't know, the National Academy for State Health Policy is a national organization that is of, by, and for state health policymakers. We work with state health policymakers from Medicaid, the children's health insurance programs in states, insurance exchanges, state mental health agencies, in some cases public health, to really help identify, promote, and then provide technical assistance around those policy and program levers for change that we've been talking about this morning. So a lot of our work is really around those state policy levers and how states can promote and spread best practices across the country. We focus on issues of access to care, systems, and coverage. Our work is guided and driven by state health policymaker input. We actually have an academy of folks who guide our work. I will say that we hear from our Academy members, and we know from what we scan and look at every day that health reform and health transformation is occurring rapidly. Someone said that earlier today. We're at a time of unprecedented change in this country as it relates to health care broadly and health generally. And we try to provide technical assistance to our members and also to others on that. I also want to say that behavioral health is a top priority for state health policymakers. We hear and work a lot with state Medicaid agencies in particular, and CHIP and insurance exchanges, but others, as I mentioned. And behavioral health is a key priority. It has risen to, if not the top three of their list. And yes, we see a lot of work being done around the country for adults, but I will say that I'm a glass half full person, and I think that a lot of the reforms that we're seeing are really have a particular impact and implications for children and families. And so I think that's been my mantra lately, especially as I lead the work on behavioral health at NASHB, to say not only for adults but for children, that so much of the reforms that are happening we know are going to have, if not already, many states are thinking about children, not all, but children are starting to become part of a lot of the reforms that are happening in states, and we think that'll happen even more. And so I'll just leave it at that as part of my opening remarks, and to say thank you again for inviting us.
Great, thank you. How many of you took an economics course in college? Great. Okay, you remember your basic supply and demand curve. We are the demand side. So my job is to generate demand by policymakers for the wonderful services that you all provide and design. So I run Ready Nation, which is a national business membership organization of more than 1,000 executives, from Fortune 500 CEOs, current and former, to small business owners who maybe just went to high school with the Senate Majority Leader. So we support our members to reach out to policymakers and say, we care about the workforce of the present and the workforce of the future. We care about economic growth, and we think the best thing that we can do to promote the workforce of the future is to invest in kids and get them to a good start in life so that they will become not only the employees we need, but the citizens and neighbors that we need as well. We are part of an organization that has 4 other related groups that each mobilizes a different type of high-level, unexpected messenger. And when I tell you what they are, you'll understand why they care so much about behavioral health and health in general. So the first one is Fight Crime, Invest in Kids. It is 5,000 law enforcement leaders, police chiefs, sheriffs, district attorneys, attorneys general. You can see why they really care about the behavioral health of young people starting in the earliest years and then going through adolescence. And they belong to us because they believe the best way to reduce crime is not to build more prisons, but to invest in kids. The second group is Mission Readiness, which is 500 retired admirals and generals, only flag officers. They care deeply about the defense readiness of the country, and they know that in order to have a safe and secure country, we need to start early to grow kids who can qualify to serve in the military and serve in any other careers. Currently, about 70% of young adults between the ages of 17 and 24 cannot qualify to be an Army private. That was data that was developed by the Department of Defense, but popularized by our group called Mission Readiness. And the same things that disqualify them for being an Army private, obesity, drug abuse, mental illness, prison record, inability to pass a written exam, etc., they're obviously related to health, and they obviously are very similar to the same kind of qualifications you need to get a job at UPS or any place else. So you can see that each of them, and then 2 other organizations I should mention that are newer. One is Shepherding the Next Generation, which mobilizes conservative evangelical religious leaders to advocate for public funding for investments in kids. Not the usual kind of liberal Protestant, but the truly conservatives who can reach the most conservative policymakers. And then Champions for America's Future, which is elite athletes and coaches, Olympians, professional tennis players, etc. So you can see for each of them, kids is not their day job. And that's what makes them a powerful spokesperson for exactly the kinds of high quality services that you all provide and that need to be funded by public dollars. So if I have one request to make of you, is that we need your data. We, especially for our business leaders, 'cause that's the group that I run, so I'm going to focus on that, is that we build their trust by saying that when we set you up to go meet with a member of Congress or your governor or signing an op-ed, that we are asking you to advocate for services that have hard data behind them that shows they translate into outcomes that we can all understand and that are important for healthy, productive adults. And so the more degree to which you can relate what you're treating and seeing in young people to later outcomes, later even workplace behaviors, the easier it is for me to get the former CEO of Procter & Gamble, the current chairman of General Motors, as two people who belong to our group, to say to their legislators, we should invest in getting children off to a good start.
Okay, so now we're going to turn to our getting your perspective on our overarching question. And as you recall, we're all focused on the ACA and health reform, very broadly speaking. And so from your vantage point, what are the biggest changes that create the greatest opportunity for preventing risk, intervening when necessary, and promoting mental health for children and families? And just from listening to you all, these organizations have been around much longer than the ACA and health reform, and in some cases, you all have been using integrated health models. So we'd really like to get your thinking on how we can move forward and continue to move forward at a quick pace in terms of taking advantage of ACA and health reform opportunities.
Great. So I think a lot of what we've talked about this morning and into this afternoon still rings true and certainly is part of the work that we do, which is really thinking about the better integration of physical and mental health, which is much more prevalent in ACA than it was before, and then creating the formal linkages between human and medical services. So, I mean, I think some of the examples of this that we see in the work we do with teams on the ground is better access to care coordination and patient navigation, better funding streams for those activities, reimbursement for services like Project Launch, so thinking about prevention in early childhood and how important that can be. I think there are still a lot of opportunities actually beyond the ACA. One thing that concerns me as we think about reform is that the more we focus on the high costs, high utilizers, the more we have a potential to miss really the people in highest need, right? So the kids I'm most worried about are the kids who don't go to school and don't go to clinic and don't go anywhere else. And we still really haven't figured out how to find them. But also, the more we focus our efforts on those people who we think show up maybe too much, potentially the further we're getting away from putting resources to finding the kids who need us the most. So I'll stop there for now.
Very interesting for us to be in a room negotiating with payers pre-ACA and post-ACA. So in terms of the biggest opportunity for us as a provider organization and also for CFHA and PCPCC, number one is flexibility in payment and even an openness to look beyond the fee-for-service model, which has been so challenging for us to try to do anything different. The level of care coordination, consultation, integration, we used to describe this to our payers, and they would have actuaries and coders in a room that, like, those coding books are this big, and they would be like, well, there's no code to describe what you're saying, so we're not going to pay for it. So, so now finally, I think there's more openness and flexibility, so people are at least talking about giving providers and organizations and other stakeholders some flexibility if you can show outcomes, which we really want. I mean, we say bring it on. We want people to look at outcomes. Before, we were just in a very churning, patient mode or as a system. We did not want to do that. So I would say number one is we have more flexibility now because I think there's some degrees of freedom in terms of financing and payment that has been very good for us in general. The problem is, and that's why I was just like applauding you. I couldn't, I wanted to stand up. The issue for us, the challenge is that still payers are focused on their most expensive cases. And so for that, it's typically older people who have 3 or more chronic health conditions. We're a safety net organization. So for us, 6 or more chronic health conditions. They're high utilizers of the ER. They're in the hospital quite a bit, and that's where they want us to put all our resources. So when, what they don't really like is that we put our psychologists and case managers in well child checks, and we put people in the schools because they're like, well, if you would just focus on this top 5% that's that is really, really contributing to our medical loss ratio, it would be better. And so we have continued to take a stand, but I think we have to be very careful because on paper, very quickly, you can get a big bang for your buck just dealing with utilizing the chronic care model. But we're just perpetuating the same thing, and then we're just going to keep getting more and more of the same generation. If we want to see long-term change, we're going to have to intervene much earlier before people, when these kids are on the trajectory. It's interesting, we can't get paid. I saw an 8-year-old girl with, she weighed 240 pounds. And we couldn't get her we have an obesity program, and we had her in that. The insurance company wouldn't pay for that. They said, well, she has to get diabetes first. This is just not the way we want to do it. So I think there's opportunity for sure, but we have to be careful about where that takes us. The workforce development piece, I think someone had mentioned, is huge. We are desperate in terms of needing providers and any team members that really enjoys, committed to working with children and families. It's hard enough to get providers, period. Okay, I mean, we hire, it's such a challenge. And then you want to get providers who want to work with the most challenging population, and not just the kids, but their parents and all the school systems and DCS. So I think the ACA's emphasis on workforce development is something we're very excited about, and I hope can only grow. So I'll stop there.
Ditto to everything Parinda said. I want to go back to 2010 just to focus on what was going on around the policy environment. And what my organization was focused on was communicating to Congress as well as we could, being a small advocacy organization, that the safety net will not go away. You can provide all the insurance coverage that you want for children and families, and they are still going to need systems of care that will see them. And school-based health centers see a lot of kids with insurance cards that they've never seen their primary care provider. So our message to Congress and the health policymakers is we still need the community health centers and the school-based health centers. We still need the safety net. What we were trying to do through that law was to get school-based health centers embedded in the essential community provider language. We did not succeed at that, I'm sad to tell you. And we were trying to get an ongoing authorization for funding for school-based health centers out of the federal government. We don't have one yet, shamefully so, I'm embarrassed to tell you. They are one of the few safety net providers that does not have a dedicated stream of resources from the federal government exclusive for school-based health centers. Well, what did happen was Congress earmarked $200 million in mandatory money out of the act for the capital and construction of school-based health centers across the country over a period of about 3 years. So we had a good 3 years between 2010 and 2013 where the federal government was actually committing grant funds to communities to expand school-based health centers. Now, they had no money to help these programs operate once they built them, but at least we had the bricks and mortar, and we were happy to take that. But so that was the context for how we were trying to bring school-based health centers into the coverage conversation. With regard to reforms around payment and delivery systems, we're just not there. We aren't figured in any of the conversations that are happening around the country, either those that are instigated by the Affordable Care Act or those that the states are doing themselves, not in any significant way, I should say. And I think the theme today has been that the energy, the oxygen in the room is about the most expensive patients, that the horizon of change is right about here. How many, is Ellen Marie still here? I don't know. How many remember the first CMS Innovation Grant Award application? Do you remember the number of months that the grantees were required to demonstrate cost savings to the system within that first year of the operation of the grant? 3 months. That within 3 months you were supposed to demonstrate cost savings to your system through that grant program. I can tell you school-based health centers, we're gonna have a really hard time making a case for that. Our change horizon is still right here. My theory of change about innovation, this is John's law about innovation, is that the further you are from the medical complex, the less likely that innovation will cross your threshold. Got it? It's just, we are not thinking downstream about these upstream providers. That's the irony, is the further upstream you are in prevention, the more downstream you are in the resource allocation. There's some great stuff happening around patient-centered medical homes. Development and school-based health centers in some communities are being thought of as eligible for that. I think if we set the bar too high, we're going to lose a lot of really good providers, not just school-based health centers, but other pediatric practices, if we continue to create a high standard around patient-centered medical home. Innovation, as I said, has not been, schools have not figured in it very much. I'm happy to say that Nemours in Delaware has an innovation award that's focused on, that includes school health systems in their work. Miami and Orlando, interestingly enough, 2 Florida communities, both have innovation awards that are focused on integration of school-based healthcare in their transformation work. And I was delighted to hear Kelly again today talking about their pediatric accountable care organization and involving schools. So it is happening, but in very, very a minority of communities. In Oregon, the care coordination organizations there are very much engaging the school-based health centers. But with regard to payment mechanisms, enhanced payment, I think they're still trying to figure that out. How do we pay for these upstream providers under a global budget? When we've got high need costs, we need to continue to expense, but we also need to figure out how do we pay for prevention. So I think there's still some tension there. And as when I last talked to my providers in Oregon, you know, they're still being paid fee for service. And my guess is that's probably going to continue for some time, that those kinds of innovations just aren't going to make it down to that world for a while. So I will stop there.
John's always a hard act to follow. I think I'll focus my comments in 4 areas. I think the first has already been mentioned, that the triple aim, the focus on the triple aim is certainly an important opportunity for a 2-generational approach to behavioral health. We've seen the federal government support the triple aim with obviously lots of investments, SIM being one of them, and in a whole host of other areas, patient-centered medical homes, accountable care organizations, multi-payer payment reforms. Those have already all been mentioned, but I think they're just a really key opportunity for the 2-generational approach. I think there's also second, lots of provisions within the ACA that really help us focus on a 2-generational approach. Some of them have already been mentioned today. MCV, the Maternal Infant Early Childhood Home Visiting Program, is one. I think Neil mentioned that this morning, and we know that that is an opportunity to really promote a 2-generational approach between pregnant women and children. The issue that Neil mentioned, and as we know, is that it's only touching a small percentage of those women who need home visits. Another important provision that I think offers a 2-generational approach is the health homes option, which has already again been mentioned, but just want to say NASHB's done a lot of work in that area. We are really tracking that very closely, and as many of you may know, many states have looked to that provision to focus on behavioral health and are including children, Iowa being one of them, and Julie Beckett's nodding her head. A third area that I think is a really big opportunity under the ACA for a 2-generational approach is just the expansion of, it got mentioned briefly, and I think we're all assuming this, but just the opportunity for states to expand Medicaid for those under 138% of the federal poverty level, adults. And I think the staff have a slide. I brought one slide, and it's actually a Kaiser slide, which many of you are probably familiar with. But we know that not all states are taking up that option in terms of expanding Medicaid. And yet we know the benefit of adult coverage for children's coverage. There it is. We know that if adults have coverage, their children will have more likely to have coverage. We know that when it comes to children's mental health, that adult mental health impacts child mental health, right? If we have untreated mental health illness in adults, that's going to have a significant impact on children. So I would just say that I think this is a huge opportunity, and we know that many states have taken it up, but many have not. And the states that have not taken it up are in some ways the states with many of the highest need. We also know that this will impact most low-income families. We know that the most likely to be uninsured are those who are low income. I also want to say one other thing about coverage. I think we all know in this room that children, and it's been mentioned earlier today, this morning, that children really largely enjoy insurance coverage, right? Most kids in this country, thanks to Medicaid and the Children's Health Insurance Program, CHIP, are insured. CHIP is not, as you know, guaranteed. The future of CHIP is not a guarantee. So I think that is something that we need to have on our priority list in terms of really looking to children's coverage. I mean, I think we have enjoyed since 1997 CHIP and all of the benefits that children's coverage has made for kids, and it certainly is an impact on children's mental health. And then the fourth area that I'll just mention is I think the ACA obviously afforded mental health coverage, right, for adults and children. And yet I think that, at least from what I've seen, we don't really have a good sense of how much, so what does mental health coverage look like in insurance exchanges? I don't know that we know that yet. I think it's something that's a big area for research, so I'll put that on the list for future study. NASHB is doing some work with RTI and with support from ASPE to look at behavioral health coverage in the small group insurance marketplace. That work won't be available though for about a year. But I do think, just the whole, a look at what is children's coverage and for mental health services really look like, especially in the insurance marketplace and elsewhere, is really important.
Great. Well, actually, I was going to talk about McV and CHIP, and Karen did such a good job on that I'll have pretty short remarks. But I do just really want to emphasize McV, and I'm sure you all know the kind of halfway home status that we're in right now with it having passed the House, and we were hoping it would pass the Senate before break, but it didn't. So we are doing an all-out campaign on that. And if any of you get the Washington Post, you may have seen an op-ed by the police chief in Montgomery County talking about why we need McV. Why did a police chief talk about why we need home visiting? Well, because we asked him to, and because he sees the crime benefits of that. And so again, my remarks are going to be less on how to implement these laws and how to defend them and how to build support for them. So one is just to really emphasize the relationship between ACA, McV, CHIP, et cetera, and workplace outcomes and behavior. So showing how they keep employees on the job now because they're healthy if they're young adults, if their children are healthy, et cetera, how it keeps employer costs down, both the direct costs as well as other costs related to absenteeism or workplace problems. Any employer will tell you that many more people get fired because of interpersonal dynamics than because of their cognitive skills. And of course, those are directly related to the health status of young people and the kind of health services that they get. So I just really wanted to stress the need for building support among all of these people who have a very vested interest in better health outcomes, but don't get their paychecks determined by the healthcare system as allies in fighting to keep these great programs.
Okay, thank you. So we are getting close to running out of our time. So what I'd like to do now is, if you do have questions, could you go to the mics so I can get a gauge of how many folks here want to ask questions of our panelists? Okay. All right, so in the interest of time, we're going to move to our questions, and then we can always follow up with you. I did have a couple other questions here, but we can follow up after the meeting on that. All right. Okay, so we'll go over here to this side of the room. Hi, Shep.
Thank you, Belinda, and thank you, Ron. I wanted to bear down a little bit on the question of school-based healthcare, and in particular, what I think is a really major threatening issue at the moment, and that is that ACA requires information systems for tracking people over time within catchment areas. The No Child Left Behind Act, going back a few years and dipping into the history of the act as a school-based, curriculum and instruction-based enterprise, they have an information system that they in fact developed. The effort was to try to standardize information across states, to at least to a limited degree, and allow a fair amount of freedom within the states and communities within states to do their own thing, because school-based education is highly community governed. That is, the oversight traditionally about the information system within schools is something that for us to work inside the schools, we have to learn to partner within. And so what's in it for us? Well, number one, if ACA goes about doing yet another information system, they cost billions. They are expensive. And I sat on a board of those safe and drug-free schools for the Department of Education for a while. At one meeting, there were 14 people who were directors of information systems who came and pleaded with this board to not do yet another, I won't say the dirty word, information system. That's 15. How many billions of dollars can we spend on uncoordinated information about children over time? So we can't just keep on doing this stuff in silos. And we have bigger silos we're talking about at this meeting, but they nevertheless are beginning to get into integration and systems of systems, as Hendricks would put it. So what we need to do is understand, A, the time is dangerous. We can't afford another information system. If we look inside what's in the school information system from a position of a public health psychiatrist, of which there are about 3, maybe 1, yeah, what you find is that everything in the school information system is relevant to health. It's all about attention, behavior, academic achievement, cognitive achievement, if you will. So all these things, how the kids make out, their absenteeism, their progression, and there are things like real markers like algebra. When kids go into middle school and they take algebra, they're on their way to college if they make it. If they don't take algebra because of prior grades or don't get good grades in algebra, forget it. The dropout rate is enormous. So we're talking about these health indicators which are buried within education, which are so central to prevention and early intervention. We have to get it together. And so when I heard the talk that you gave, and we're talking about school healthcare integrated, and you think about the opportunities for collaborative curriculum and instruction between health and education. Health and education, by the way, are the 2 fundamentals of socialization of children in general, health and education. All the rest is reparative, supportive, adds people coming in when needed in the ideal system. Anyway, I wanted to focus on the time issues and the shared mutual self-interests. Thanks.
Thank you, Shep. The two points to expand on that. One is that school-based health centers are largely disconnected from the health systems too. They don't have a very strong data interface with the larger systems of care. So there's a lot of disconnection going on between what's going on in the schools. And we used to use privacy laws, the education privacy laws under FERPA and the health privacy laws under HIPAA as cudgels to bang each other and said, I can't share this data with you. But I think communities are being smarter about that today and are figuring out a way, how do we integrate? And there are processes, there are ways to do that through consent forms. And there's one community in particular that we are watching very carefully in Miami, where they are aggregating their ed data and their health system data in a way that both systems are able to figure out where are we doing well and where are we not doing well, and how do we reallocate our resources in a way that's going to get to those hot spots where there's still tremendous need. So it can be done, and it is being done, again, on small scale.
Can I just comment on that too? I would just add, I think it's a huge issue, and I think it's something that's going to take, I mean, we've been working on this for a long time, so I'm glad you brought it up. I guess I would just add that I also think thinking about the policy levers that we can be using between education and mental health and healthcare are really critical. Illinois was the first state in the country to develop learning standards for social and emotional development that are required of every public school in Illinois. And so, you know, what does mental health in schools look like? I think that's a really good example and a policy lever, and also standards can be linked to data, so maybe a way to kind of start to get at measurement. I also think about the policy levers that we have with schools. You know, every child in this country, well, most, you know, needs an immunization before they get into, you know, when they get into kindergarten. Well, yes. Most, I said most. You know, in many states, we're seeing hearing and vision screens being required. What would it look like if we also saw developmental screens or mental health screens being required? I mean, again, thinking about those policy levers, and I know that's a little bit off topic of your point, but just the point of being about policy levers and education.
Yes, hi, my name's Sandy Steer. I'm with SAMHSA, Office of Policy Planning and Innovation, and I work specifically on workforce and integration efforts for ACA implementation. So my question today is really specific to workforce, and I've heard a number of people speak to it today, including some of you on the panel at this time. In terms of really having the workforce to meet the needs that we have today, there are a couple ways to look at it. One is to enhance the skills of the existing workforce, but also to increase the workforce. I'm interested in where you see the greatest need, enhancing skills or increasing the workforce and changing the workforce. And to that specific point, do you think that we really need to bring in more individuals from the same type of workforce we've had before, traditionally providing services, or is there an opportunity to really bring in new or sort of emerging types of workers, such as community workers, peer support providers, those type of lower level, less expensive types of providers for which we unfortunately don't have a lot of data on today to make good decisions around the policies that might support that type of expansion?
Yes, yes, yes. I mean, to be honest, we are a community healthcare organization, and we are in the inner cities, we're in the mountains. The need is so desperate. I don't think in terms of workforce, we have the luxury of picking and choosing. I think we are gonna have to bring everybody on board, as many people as we can, and at every level. Because that's, I mean, to say that any one discipline, I mean, I feel like, you know, right now we have, as we heard, children and families in tremendous suffering, living, you know, lives and having experiences they don't really need to have, or, you know, the potential is so great. So I would say we need all hands on deck. And if there's a priority, this would be it, is we need to do it all. We need to train the existing workforce. We need new people. We need new people going into existing disciplines, because some of them are just do a fantastic job. And we will have all kinds of variations of different workers. We have to go through systems like schools, teachers, churches. I mean, I think we have to use every resource available to us. So I would hope that we would not be so picky about names and titles, that we all want to just keep our eyes on the prize. And we just want a healthier set of communities for our children.
So I just want to add one thing. I work in a more resourced area of the country, and I think there it's still relevant. So we don't have a ton of data on standardized. The data is building around patient navigation and community health workers, but there is data to show that we in sort of the traditional medical community aren't particularly good at either navigating patients or at motivating them. So, you know, there's sort of data in the other direction that we're not approaching it maybe in the best way possible, and we should be using that too.
I have found that our strongest programs employ community organizers that are able to change not just the health of children or even the faculty in the school, but the health of the community by focusing on food access in the community, home visiting where children are exposed to asthma triggers in the home, and organizing around fighting tenants around the quality of housing, working around safe routes to school. So you really need, I think Jeff referred to the integrator organization, you really need somebody like that working in partnership across, you know, so across a prevention workforce, if you will, to achieve all those kinds of goals. So I do think it is a different, and it is a different kind of workforce as well.
I have just a short comment and something to think about. So I think Shep's comment is a good lead-in to mine. So I guess I'm progressively worried that we are seeing the healthcare system as the pivot to all these other issues, when we know that the healthcare system accounts for at most 10 to 20% of a person's health. That we're pivoting and building outward here. I don't hear any strategy of building inward. So if you take poverty and you take income differential, a huge issue on income differential is raising the minimum wage. We need to have other strategies than pivoting outward from the healthcare system to move the agenda here. And I see some people shaking their heads here, so I'm sure you have good comments on that. But it's a thought. We can't leave here with only one strategy, basically.
No, I mean, our job as a provider organization would be so much better if, you know, the people with whom we work, our patients, got paid a decent wage. We would not, you know, if they could eat healthier foods and live in safer places. So I just really concur with that. You're absolutely right.
Well, just want to say thank you to our wonderful panel. You were great.